Thanks. I'd like to welcome everybody to our April 2022 session of the Erie County Workforce Collaborative Training Series. The Erie County Department of Mental Health is happy to be able to offer these trainings to the dedicated providers in our community to support workforce retention and provide an opportunity for individuals from our provider community to share their expertise. Today, we are very excited to have Emma Fabian and Naomi Taylor from Evergreen Health to talk with us about harm reduction philosophy and practice. In May, we are happy to announce that the topic will be LGBTQ+ concerns for youth and families. We will be putting the registration link for this May session in the chat at the end of this session. It will also, we will also be sending out the announcement for this training in the next day or two. But you can also go to our erie.gov/mental health website for announcements and registration information. That will have our May training information on it, but also our June training registration information. And our June training is on existential therapy. All of our sessions are offered on the fourth Tuesday of the month from noon to 1, and we'd encourage you to mark your calendars and watch for notices for future events. All of the presentations and recordings for our past offerings are posted on our website, and we'd encourage you to check those out as well. At the end of this session, we will ask you to complete a very brief evaluation. We hope you'll take a moment to fill this out so that we can continue to improve. Because this is a community collaborative, we are always looking for volunteers to share their expertise with our community of providers. If you are interested in doing a 1-hour presentation or interested in a particular topic, you can indicate that in our evaluation, or you can also contact Amy Rockwood at amy.rockwood@erie.gov. This training is being recorded. Everyone is muted, so if you have questions, please put them in the chat box. Amy Rockwood from the Erie County Department of Mental Health will be monitoring the chat for us today during this session. Thanks, Amy. And again, thank you all for joining us today, and I'd like to introduce Emma Fabian and Naomi Taylor for their presentation on harm reduction philosophy and practice. Thank you so much, Naomi and Emma. It's all yours.
Kathleen and Amy, thank you so much. It is a pleasure to be here virtually today with many people across Erie County and across the region, it looks like. My name's Emma Fabian. I use she, her pronouns, and I'm the Associate Vice President of Harm Reduction, title I'm very lucky to have, at Evergreen Health in Western New York. And I'm also a part-time professor at the UB School of Social Work, where I teach about the basics of substance use treatment and understanding addiction. Just a couple housekeeping things and thank yous real quick before I jump in. A couple times I'm going to be calling upon Naomi to jump in and just add a little bit more depth to a couple of the slides. Naomi, would you take a sec to introduce yourself if you're okay with that?
Sure, thanks, Emma. Hi, everybody. Good afternoon. My name is Naomi Taylor. I work at Evergreen Health, and I am the harm reduction specialist. I help out with education around harm reduction philosophy and how we can practice that in our lives. And I also help run the Drug User Health Coalition, where persons with experience and active drug use come in and we take their feedback and we listen to practices that we can implement in the way that we help support individuals.
Perfect. Thanks, Naomi. So before we get started here, in addition to thanking Amy and Kathleen, I just, also just want to express my gratitude for being part of the opioid task force and for the partnership of the Erie County Department of Mental Health and the Department of Health. Honestly, I think that Erie County is ahead of the ball when it comes to embracing models such as harm reduction. So I feel lucky for our patients and our staff that were located here in Erie County. And honestly, since the task force's inception, I really wouldn't have the amount of partnerships and contacts and people that I can get on the phone and ask for opinions and feedback and referrals that I do have. So thank you all for being part of that. Before we begin, I just want to take a quick pause to commemorate and recognize the lives that have been lost to the overdose crisis here in Erie County since 2020. And I say 2020 because that is when COVID-19 really hit the western part of New York State and has exacerbated the overdose crisis significantly. So if you would humor me in just taking like a brief moment of silence, just to remember folks that we've lost over the past couple of years. All right, thank you for that. Moving along a little bit here. Go on to the next slide here. A couple of things that we hope folks can, a couple of things that we hope folks obtain from our conversation this afternoon about harm reduction philosophy and practice. You know, first of all, we just took a moment to commemorate folks who we've lost to the overdose crisis over the past couple of years. And just as recent as yesterday, I saw some pretty drastic, scary statistics about the fatalities due to drug overdose that occurred in 2021 in our area in the beginning of 2022. And so I think there's no better time than now to be talking about how we need to broaden the continuum of care for people who use drugs and are struggling with mental illness in our community. And a big piece of that is the harm reduction approach. So we hope that folks can be able to describe the core principles and values of the harm reduction approach after our conversation here today. We hope folks can begin to understand why and how harm reduction strategies can be implemented with people engaging in high risk behavior, particularly people who use drugs. And then we're also going to talk a little bit about stigma because it's stigma and it's stigma's prevalence in our communities that makes harm reduction especially important. I want to just take one step back to talk about the history of Evergreen Health, where Naomi and I work, where we're lucky to work, because you will see during our conversation today that our history and our mission has a lot to do with harm reduction. Evergreen Health was founded over 30 years ago as AIDS Community Services. At that point in time, and I saw the list of participants, I know there's some people like Dee Dee who are familiar with our history. But at that point in time, of over 30 years ago, we were a small but mighty organization working with folks who were diagnosed, living with HIV and AIDS, and doing some education about prevention in the community. At that point in time, unfortunately, a diagnosis of HIV and AIDS was almost what some in the medical community might call a death sentence. But over the past several decades, as people have been able to live healthier, longer, safer lives with HIV, AIDS, and other chronic illnesses, we have grown as an organization to provide a wide array of medical, supportive, and behavioral health services. And the kind of the hubs of our service provision are in Buffalo, New York, where I'm calling in from right now. But we also have a large kind of one-stop shop facility in Jamestown as well. And then we have some mobile services that go around the region, not just in Chautauqua and Erie County. A little bit about what we provide these days: medical care, including primary care, HIV and hepatitis C treatment, transgender care, testing, and an on-site pharmacy. Behavioral health services, including the area's only harm reduction center and syringe exchange program, medication-assisted treatment, including low-threshold medication-assisted treatment, or MOUD, as I should really be saying these days, and substance use and mental health counseling. So we have an on-site OASIS program, an on-site OMH program, as well as some really unique low-threshold harm reduction services. We also have a Center for Supportive Services that includes some housing and transportation services, care coordination, of course, and the Pride Center of Western New York and community access services are part of our organization at Evergreen. moving along a little bit, what we're here to talk about today, substance use today in 2022, and how harm reduction ought to be a really important piece of the continuum of care and us responding to substance use in our communities. I have a couple pieces of paper in front of me that are close to the laptop that's got a speaker in it. So I apologize if you occasionally hear a little rustle of paper, but I promise that won't be often. I know these things pick up a lot of noise. So in order to talk about why harm reduction right now is an appropriate response to the overdose crisis, we've got to talk about substance use itself and about how we know more these days about substance use and addiction, what substances do to our body functioning, our brain functioning, and what it means to be substance dependent. We know more about those areas than we ever have before. And looking back, we recognize, and leading researchers are recognizing that throughout history, people have always used substances to alter their states for several different reasons. Religious reasons, intellectual reasons, boredom, grief, celebration, something we're quite familiar with here in the United States in our culture, substance use coinciding with celebration. But then, of course, particularly relevant to the conversation that we're having here today, substance use for physical and emotional pain. So that's a really important piece of the context about why harm reduction. Second important thing to note is that we recognize, looking back, that historically our attempts to prohibit drugs from existing in our communities, our attempts to prohibit drugs from being in our communities, as well as our attempts to end people's drive to use substances, hasn't traditionally worked. The laws, the regulations, the policies that these days a lot will call the war on drugs or the drug war, referring particularly to the past 50 or 75 years of legislation and laws and policies in the United States aimed at curbing substance use, haven't traditionally worked. A little bit more context about substance use today. Naomi and I and some of our colleagues, just for some cut and dry statistics about substance use, often look at the UN's World Drug Report, the World Drug Report from the United Nations. Back in 2019, which is the last time we could capture data that really portrayed the prevalence of substance use in the world. Back in 2019, the report estimates that approximately 271 million people used an illicit substance in 2019. 271 million people. That's about 5.5% of the world's population. It's probably really underreported, but that's a pretty large statistic in and of itself. So 271 million people. Of that 271 million people, we'll say that's about this many people. Of that subset, approximately 35 million people meet what we would consider the clinical criteria for substance use disorder, which means having an unhealthy habit or relationship based on the DSM or the ICD with substances. So we have like this many people use illicit substances every year. It doesn't include alcohol. I'm only talking about illegal drugs. 35 million people probably develop an unhealthy relationship or unhealthy habit with those substances. And then less than 1 in 7 of those individuals receive access to substance use treatment every year, according to the United Nations World Drug Report. And then even less than 1 in 7, so we'll say this itty bitty amount of people ever receive access to substance use treatment that leads to less, we'll say lapse, or leads to an increase in health and safety in people's lives. So this many people use an illicit substance, this many people is what we're talking about, that sweet spot where we want to be, where we're providing some type of service or treatment for folks that decreases their substance use and leads to them living healthier and safer lives. If you're interested in this information, the concept of harm reduction that we're talking about today, the concept of how we know more than we ever have before about substance use and about addiction. There's a few folks that I would recommend looking up. The first individual's name is Johann Hari. His most popular book, the book that I think applies the most to this conversation, is called Chasing the Scream. And it's a fabulous book. He's well known for his TED Talks. So if you're not into reading, you know, when you go home after being a substance use and mental health counselor or administrator or nurse or whatever, and you don't feel like reading like a 400-page book about the same things that you just saw every day. I'm kidding a little bit just because we all got to be concerned about this these days, you know, burnout, self-care, all that stuff. So if it doesn't sound exciting to you to go home and read like a 400-page book, I'd still recommend Googling Johann Hari because he has a couple TED Talks, one of which has become quite popular, and it's called Everything You Think You Know About Addiction Is Wrong. And maybe, Naomi, if we have time, we can even throw a link to that in the chat box. But it's quite good. And so, yeah, Chasing the Scream by Johann Hari, terrific book, very relevant to the topics that we're talking about today. Also he tends to be somebody that's a favorite of people who I know who are living with lived experience. He's got this pretty well-known quote that says, like, the opposite of addiction isn't sobriety, it's connection. So he's got some pretty good thoughts. The second person I'd really recommend is Michelle Alexander. She's a columnist for the New York Times right now, but she also several years ago wrote a book called The New Jim Crow, still incredibly relevant right now. And a lot of the information in The New Jim Crow is about mass incarceration, particularly mass incarceration of BIPOC communities, and the intersection with drug policy. A lot of that information became the foundation for a documentary called 13, which is on Netflix and was quite popular when it came out. Anyways, almost wrapped up with being a fangirl here. Let me just mention one more book, which is my favorite right now, by an author named Maya Solovitz. She's got this book that just came out in 2021 called Undoing Drugs. And it's a fabulous book that details the history of harm reduction and talks a lot about the future of addiction treatment. Somebody just asked in the chat the name of the documentary. It's called 13th. It's on Netflix, 13th. Very good stuff. Now, Undoing Drugs is fabulous. A lot of folks are saying it should be required reading these days for people who work in the substance use field. If you're at an organization that is like Oasis, OMH, all kinds of state agencies are requiring us to think more about harm reduction in terms of providing services to our population. How the heck do we go about that? And what does harm reduction even mean? That's a lot of us. I would recommend looking at Undoing Drugs by Maya Solovitz. She's also going to be in Buffalo in the summer talking at a conference about harm reduction locally. So look out for an announcement about that. Moving along a little bit here, substance use from a biopsychosocial phenomenon. So something that I think those authors that I just showed lean on in the harm reduction approach is certainly part of this model is in the past 50 or so years in the United States, and really the globe, the whole world, but particularly here in the United States, the model through which as healthcare providers we have thought of substance use and addiction has been changing over the past 50 or so years. And I'm talking about us formerly thinking about substance use through a moral model and a punitive model. So when I think back 50 or so years, I think about reading about the traditional approach to substance use being either thinking about people as product of a criminal mind or a moral failure, and thinking that folks have got to be kind of isolated from the rest of society or locked up and that is the way to approach substance use. Okay, so the kind of moral punitive model that we used to think a lot through in the United States. And then gradually we kind of moved into this disease model or the medical model. And by that, I describe the past 25 or 30 years where we have thought of people who use drugs as very, very sick. And they're going to be sick forever. They have a disease. They've got to get in treatment forever for the rest of their lives, or else they're in denial about their problem. We're now moving into more of a biopsychosocial model. Some folks refer to as the biopsychosocial spiritual model. And it's also known in some academic settings as the public health model. And it basically recognizes that, this substance use and addiction stuff is neither just purely like a medical disease, and it's not just like evidence that somebody is a moral failure or a criminal and they got to be kind of like put away in a hospital or a jail for the rest of their lives. But instead, we're recognizing that there are a lot of biological, social, and psychological reasons why people use drugs initially and why they continue to use substances. And so this stuff isn't going to come as rocket science at all, I don't think, to any of the folks that are joining us today. But humor me while I name, because we're going to keep this in mind for the rest of our time together this afternoon. Bear with me while I name some of the factors that I'm talking about when I'm talking about substance use as a biopsychosocial phenomenon. So this trend towards harm reduction, this trend towards thinking about substance use and addiction through a different model, recognizes that some of the psychological factors leading people to use substances has to do with it being a learned behavior, mental health, grief and loss, self-esteem, helplessness and hopelessness, and loss of identity. Some of the biological reasons have to do with injury, chronic illness, relief from pain, that physical and emotional pain that we talked about earlier, complex trauma. We know way more than ever before about the role that trauma plays in the lives of human beings, including even the impact on different parts of our brain. Physical withdrawal, physical dependence, of course, especially relevant when we're talking about opioids and alcohol, cognitive delay, and genetic predisposition. Some of the social pieces, factors for why people initially use substances and continue to use substances is loss of support, loss of social support. COVID-19 has really shone a light on that, as a factor leading people to use substances. Engaging in survival sex or sex work, unstable housing, big issue here in Western New York, negative experience with systems, and institutionalization, in other words, involvement in the legal and criminal justice system. So a little bit about the history of what we know now as the harm reduction approach. Harm reduction was popularized during the rise of the HIV and AIDS epidemic, the 1980s, early 1990s. And as an example of why we look to that time as the rise of the harm reduction model is programs like needle exchanges and condoms programs drastically reduce the rates of new HIV transmissions, particularly here in New York State, where we were an early adopter of those types of public health interventions. Needle exchange programs, condoms programs, kind of the most well-known examples of a harm reduction intervention. Now we see harm reduction applied to an array of public health issues and social justice issues, including things like Narcan, when it comes to the overdose crisis and opioid use in our communities. Can't even really begin to think about what our fatal overdose statistics would look like if it weren't for the widespread availability of and access to Narcan or naloxone. So again, popularized in the 1980s and 1990s as a response to HIV and AIDS, now applied to a wide variety of issues, particularly right now, working with people who use drugs. So now that I've talked a lot about why harm reduction is so relevant and important right now, and provided some examples historically of harm reduction, let me pause for a second and just provide, I think, what is the most accessible definition of harm reduction. And it comes from a group called the National Harm Reduction Coalition, a group, and they do a ton of capacity building and education in the United States. They say that harm reduction is a set of public health strategies and ideas aimed at reducing the negative consequences of drug use and other high-risk behavior. For us here at Evergreen, over the course of time, what we've learned is that a few important cornerstones of doing harm reduction work that complement this definition are the following. Harm reduction is a patient-centered approach that's respectful of the inherent dignity of all people. Patient-centered approach, person-centered approach, if you will, respectful of the inherent dignity of all people. Second, harm reduction emphasizes social justice. In fact, these days, a lot of folks in harm reduction work will say that harm reduction equals public health plus social justice. Harm reduction equals public health plus social justice, which I think is interesting. Social justice, obviously a little bit of a buzz term these days in our society. What I'm referring to when I say social justice is recognizing that the distribution of resources and the distribution of access in our society is not justly distributed. So harm reduction recognizes, first of all, that substance use in a lot of ways is folks' means of coping or adapting with an unequal access to resources. Second, we recognize that through harm reduction, that folks' access to treatment, services, resources, capital to respond to their substance use or addiction, that access also isn't equally distributed. So that's, just a little bit of what we're talking about when we're talking about harm reduction and social justice. Finally, when we're talking about harm reduction, we're talking about going to work every day with the population of people who use drugs, armed with a toolbox that has lots of different tools in it that can be different tools used to adequately match where people are at in their substance use. What I mean by that is harm reduction is an umbrella term that encompasses interventions that range from helping people use safer to helping people manage their use, to helping people work towards abstinence. So again, it's like a toolbox armed with lots of different tools that can help people use safer, help people manage their use, or help people work towards abstinence if that's what they are wanting, ready, needing to work on. Some examples of harm reduction interventions, some of these are in our everyday lives, are things like seatbelts. Okay, every time we put on a seatbelt, we are what the Harm Reduction Coalition would call reducing the potentially negative consequences associated with a high-risk behavior. Sexual health education that's based in fact and not fear. Needle exchanges, like I mentioned already, condoms programs, PrEP or pre-exposure prophylaxis, medication adherence in general, fat-free, gluten-free foods or wellness programming in general, domestic violence safety planning. Any of us who have ever worked in the domestic violence field know that really the go-to intervention with folks is to create a safety plan. And that is really just a plan about reducing risk. And just to take that a step further, because I used to work in the domestic violence field, it's not only about the tactics that are within that safety plan that you create with a person who's going through a domestic violence situation, but it's also about building trust and rapport with folks so that if somebody is needing or ready to make a bigger change in their lives, they have someone that they've built trust and rapport with. Self-injury and suicide prevention work, and some forms of community advocacy. Okay. I'm going to move from talking just really broadly and philosophically for a couple minutes or a couple slides here into talking about how harm reduction is practiced in behavioral health and medical healthcare settings. And we call these the harm reduction principles. First of all, harm reduction is about building rapport and trust for a few reasons. First of all, trust, let me say this. First of all, a lot of the folks that we are seeing in the harm reduction setting who are actively using substances have, in a lot of cases, tried treatment many, many times, been involved in the criminal legal system, and in some cases have some understandable mistrust of systems in general. And building trust and rapport with folks is always our first focus. The second thing is that, and a lot of you who work in the field will understand what I say when I mean this. Trust and kindness can be transformative. Trust and kindness can be transformative, and that's a big part of the harm reduction approach. In the time that I've been working here at Evergreen Health, when I look at like patient feedback surveys, or when I help facilitate groups of people who are former patients or current patients, time and time again, what people remark about that's the memorable thing about Evergreen Health, or the thing that they like the most, is that they feel welcomed and they don't feel judged. And those things in and of themselves can be transformative for people who are going through a difficult time, whether it be chaotic substance use or mental health. Second huge part of the harm reduction approach is something that we call celebrating any small step towards reducing harm. There was a well-known harm reductionist who unfortunately passed away a few years ago, who was popular for saying any positive change. We're here to root for people to make any positive change. First of all, celebrating any positive change is practical. And the reason I call it practical or pragmatic is because change doesn't happen overnight for none of us. Change doesn't happen overnight. So celebrating small steps towards reducing harm is practical. Change doesn't happen overnight. But second, it keeps people engaged. And I'll tell you a story, I'll give you a little example about this. And I apologize to anybody who has ever worked with me or even just heard me talk about harm reduction work before, because you've probably heard me tell this story. When my office is in the back of our syringe exchange, our large syringe exchange program here in Buffalo is where I primarily work. And for the past several years that I've been here, one of my favorite things to do is when I hear or see someone walk into our syringe exchange program who hasn't been here in a while, maybe I heard through some case conferences that I attend that they weren't doing well, something happened, they hadn't been in a while, or maybe I just noticed their absence. When I hear or see someone who hasn't been in a while, I make the biggest effing deal and go try to treat them like $1 million. I will put my arm around somebody's shoulder, give them a hug if that seems okay. Look them right in the eyes and shake their hand with my 2 hands and just say, "It's really good to see you. You look great. Why don't you come on into my office or come on into the waiting room, have a seat, let's get you some coffee. How do you take your coffee? Oh, that's right. Let's get you a granola bar and some snacks. Let me show you some of the new services we have these days, because I know you haven't been in a minute. How's everything going? Let me go find who you're here to see. Don't worry about a thing. People are going to be so happy to see you. I'm going to go get the person we're working with." Celebrating any small step means even celebrating that people took the step to show up. So how do you think that would make you feel? Can you put some responses in the chat box about how you think that approach would make you feel. You're a somebody who actively uses substances because you're enrolled in a syringe exchange program. You haven't been in a while because a lot's been going on, and the associate vice president of harm reduction greeted you that way. Valued and supported, very welcomed and judgment free, cared for, noticed, accepted. Hi, Jen Servey. So yeah, I mean, I'm not even going to go into it much further, except to say, and I know that this is kind of, hi Anne, I know this is kind of corny, but think for a second about places in your community or people in your family or friend circle that you really like being around, or places in your community where you really like going, where you feel frequented. I don't care if it's a dry cleaners, a coffee shop, a restaurant, hi Tara, a pharmacy, or whether it's the way your mother or your best friend makes you feel. Just think about those concepts, and you don't need to answer this, but do they also align with the things that you just named? Seen, safe, accepted, welcomed, not judged, cared for, relieved and happy. I like that one. So you don't need to answer that. It's a rhetorical question. And I know it's corny, but that's where we're going today. Next thing about, let me just get the checkbox out here. Next thing, when we're talking about the harm reduction principles, is recognizing the need for low threshold services. Low threshold is also another one of those kind of buzz terms in behavioral health and in healthcare these days. But what I mean when I say low threshold is lowering the barrier to accessing services. So some examples of lowering the threshold to accessing services is things like making some services drop in, right? Like the way that we have made Narcan and naloxone really available in Erie County, the way that you can kind of walk into a lot of places and say you recently used Narcan and get another kit, that's low threshold. The way that you can walk into a syringe exchange program and declare what you think you need to keep you and your family safe, that's low threshold. We've been operating for several years now here at Evergreen, a low threshold buprenorphine program that we just expanded into the Jamestown area, Chautauqua County. And some examples of how we choose to keep that low threshold is not mandating people to take part in behavioral health counseling, being really flexible with folks when they can't show up for appointments, working with people before their insurance situations are straightened out completely, using the toxicology as ways to educate our patients. And there's some other examples as well, but I think you're catching on if you haven't already. So the need for some low threshold services in our communities is a big part of doing harm reduction work. Now we know not all programs, not every single provider is going to be low threshold in the same ways that I just named. Okay, we recognize that. I don't live in la la land. But to respond to this overdose crisis, especially what we're seeing during COVID-19, we have got to have some ways for people to get their feet in the door of those concepts that you all just named in the chat. We got to have some way for people to get their feet into the healthcare system, into community, and so forth. The data that I see time and time again about our low threshold program is that upwards of 80% of the people in our low threshold buprenorphine program have been through treatment multiple times. Not once, multiple times. Upwards of 80% at least. Now this is self-reported for the most part. I mean, our providers ask the questions, but it's for the most part self-reported. Upwards of 80% have at least one mental health diagnosis. So these are folks that we got to figure out some way to get them linked up with a level of service. Focusing on strengths, again, focusing on strengths. Upwards of 80% of our folks in the low threshold buprenorphine program over the course of time tried treatment multiple times. You might look at that as somebody who has, and now, I know unfortunately we use terminology like this in the field, somebody who's been like a revolving door in and out of treatment. Sometimes we'll say they're like a frequent flyer in the treatment world. We have all kinds of ways to that we code saying, I don't really believe treatment's gonna be successful for this individual. They've been through it a million times, but whatever, they're here. We got all this coded language to describe patients like that. But what I will say is, when we try to look at that as a strength, this person has engaged in treatment so many times and they're here again, and this is another opportunity for us to integrate some health and safety into their lives and celebrate the small steps towards reducing harm with them. We always have to focus on people's strengths. Another thing harm reduction calls for us to focus on is input from directly impacted people. It's a big deal for us here at Evergreen Health, probably because of our roots in the HIV and AIDS epidemic. But input from directly impacted people is big for us here. Naomi and I, probably one of the biggest parts of our week every week is that we have an in-person Drug User Health Coalition meeting every week here in the Harm Reduction Center. It's a consumer feedback and advocacy group composed of people who have been in our harm reduction services in the past or are currently in the harm reduction programs. And they provide all kinds of amazing feedback to us. For instance, over the past half a year, they've helped us understand that we've got to expand our physical space, our physical non-judgmental welcoming space for people who use drugs, where people can come and hang out and do things like get some clothes washed, take a shower, get some snacks, engage in some open groups and that type of thing. And we took that seriously. And so we'll be rolling out some of those new spaces in the next couple weeks. So anyways, input from directly impacted people is one of those things where, like, if you're thinking of what the next steps are for like your organization or a group or something like that, to delve a little bit further into harm reduction, you've got to have a group of directly impacted people that you are consistently soliciting input from and utilizing the input from. Okay, it's not like they fill out surveys and then you like put some of the survey results in a spreadsheet and then nobody ever looks at it again. Not that type of input. Well, really, when I hear people say that they do harm reduction work and they don't have that proximity and relationship with directly impacted people, it kind of makes me wonder these days. Non-judgment and cultural competency, beautiful part of harm reduction that I know just from seeing who's on the call today, folks are quite familiar with. Keeping patients engaged even when they display challenging symptoms of the diseases, behaviors, and social conditions that make them eligible for services. Now, this piece is a big deal. It's time consuming. It takes a lot of energy. It's easier said than done. It's what myself and some of my colleagues end up spending a lot of time working on, is when people, for whatever reason, aren't doing well. Maybe there was an outburst in the lobby. Maybe they yelled at somebody at the front desk. Oh, those are tough moments. But maybe they're not showing up for appointments. Maybe there's XYZ things that could be going on with them and the way that it's showing up. You want to, in the harm reduction world, work really hard at figuring out some way to keep them engaged. Figuring out some way to still allow them to have access to support and services. A lot of times the behaviors are like associated with the things that make them eligible to come to us in the first place, right? Like, these are the folks that we want here getting the assistance. And then lastly, harm reduction is recognizing the role of stigma. Just gonna move along. I'm only gonna talk for maybe 5, 6, 7 more minutes and then see if people have questions, comments, concerns, anything that they would like to share. Does that sound okay, Amy and Kathleen, if we just move through and then we see, what questions, comments, concerns folks have? Now that we've talked a little bit about the harm reduction principles and what harm reduction is, I just want to name what harm reduction is not. When we're practicing harm reduction, we're not ignoring the real harms associated with behavior such as drug use, all right? We're not saying, you know, that we think we would like to see more people use drugs. We'd like to see, you know, more people struggling in our communities. That we actually think that there's something really incredibly healthy about using substances. That's not what harm reduction is. It's recognizing that all people have inherent human dignity that we need to maintain while we're providing healthcare and behavioral health services. And we're recognizing that people have always used drugs throughout the course of time. People have always used drugs. Some people are probably always going to use some substance. That doesn't mean that there aren't ways that we can integrate health and safety and community into their lives. Just to touch really quick a little bit more about how we're seeing right now that harm reduction's got to be a really important part of our response to the current trends in the overdose crisis. I wonder if most people on the call here are familiar with the theory of the 3 waves of the overdose crisis. First wave being in the early part of the 2000s with a rise in deaths due to prescription opioids. Second wave being a rise in heroin-related deaths due to a rise in deaths, overdose deaths due to heroin. And then the third wave, what we used to, unfortunately, think of as the height of the overdose crisis, wasn't, at least here in Erie County, like 2015, 2016, 2007, well, 2015, 2016, when deaths due to fentanyl really spiked. Okay, so a lot of researchers and experts these days are thinking of the overdose crisis in those waves. I think what we're within right now is actually a 4th wave of the overdose crisis, and it don't seem to be any signs of it slowing down, unfortunately, unless we do something incredibly differently and fast. The 4th wave, what I'm talking about, is a rise in overdose deaths due to fentanyl, and fentanyl not only being in what people think they're buying when they're buying dope or opiates and that sort of thing, but also fentanyl in the supplies of cocaine and methamphetamine and other substances, and just really strong fentanyl in general, even when it's in dope. And that combined with the factors surrounding COVID-19, isolation, lack of social support, lack of connection, and in some ways, this pattern kind of out of necessity in our culture to be like, oh, other people, I'm afraid of them. They could have COVID-19, or, oh, that person looks, you know, unhygienic. I don't want to be near that person. I feel kind of okay making a face at them, in fact, because, you know, COVID-19 has given us the okay to just be really afraid, almost like even vocally and outwardly afraid of other people. That type of stuff, I think, is going to be really scary for people who are struggling with mental health and substance use. Accidental overdose is still the leading cause of death, accidental death. That's written a little bit wrong. Drug overdose is really the leading cause of accidental death in the US for folks under 50. Using overdose crisis, not opioid epidemic, is an important thing for us here, particularly because of this concept of the waves of the overdose crisis and us being in a 4th wave. We've got to kick the opioid epidemic language, because we're not just talking about what we've traditionally thought of as heroin or dope or opioids anymore. Fentanyl has probably changed the nature of illicit street drugs forever in the United States. And so we've got to get serious about not just labeling it opioid epidemic. The other thing is, I think over the past 10 or 15 years, the term opioid epidemic, what most people call to mind, whether it's, and this is partially just kind of something that's been spun, and it could be a little bit of a myth, but you know, the thing that we think of or visualize when we think of opioid epidemic these days, unfortunately, is this idea that even suburban white families and children have now been impacted by substance use. So we've got to have a bigger response as a government and as a community. And I just think we don't want to unintentionally perpetuate that. And so it's really more appropriate to use the term overdose at this point. The local overdose crisis, for the sake of time, I know folks that are on the WebEx call today actually are probably familiar with this information, but it's deaths due to fentanyl that are increasing in our communities right now. It's not deaths due to heroin. And so I think that's just something that we've got to keep in mind. A little bit more contributing factors right now to the current crisis that's been exacerbated during COVID-19. Initially pharmaceutical companies in the 1990s did increase prescriptions of opioids, but that's not the only explanation for the crisis that we're seeing right now. Drug use is a way to cope for a lot of people. There's not enough adequate treatment to go around. The stigma involved in the stigma facing people who use drugs is still really severe and in a lot of ways a barrier towards care. In the war on drugs, the prohibition of certain substances, some researchers and experts suggest, actually leads to more dangerous substances popping up and infiltrating the illicit drug supply. For me, this all comes down to the stages of change, and this is one of the things that I'm going to leave it at before we move into questions. I mentioned earlier that in addition to being, in addition to working here at Evergreen Health every day, I also am fortunate to teach at the UB School of Social Work part-time. And around this time in the semester, students are wrapping up their paper. And one of the final assignments in a class that I do is a treatment plan. You got to create a treatment plan for a case study. And our whole semester has kind of been leading up, giving students the tools to create this treatment plan for a case study. The first assignment of the semester is doing an assessment on the case study. And then at the end of the semester, they write a treatment plan. And in the assessment, students generally do very well on this assessment. You have to stage, part of the assessment is you stage our case study. His name is Dave, and totally fictitious name, but a lot of the students put Dave in pre-contemplation around opiates. He's a little bit more contemplative around alcohol. He's got a few substances that are his drug of choice. But they pretty much stick with pre-contemplation, contemplation. A couple people say preparation or planning, and I think that's, they put a lot of evidence in there, so it's all well and good. And of course, this is all about staging the case's place on the stages of change, his readiness, his access to resources to engage in change regarding his substance use. So they do well on that assessment paper. But when the treatment plan comes around, even though students placed him in contemplation, in pre-contemplation and so forth, the treatment plan includes tactics like Dave's going to go away to a 90-day program. Dave's going to go 3 times a week to marriage counseling with his wife, Melanie. Dave is going to be abstinent from alcohol and opiate use. So the thing I'm getting at here, and I almost get so by the end of the semester, I just kind of copy and paste this into papers. I hope there are no students who have ever taken my class on this call today. But the thing is, those interventions could be good long-term goals for Dave. They don't really match where he's at, right now. And if we're serious about responding to this overdose crisis, we have got to invest more in services in the earlier stages of change in our communities. We've got to have interventions for people who are in pre-contemplation, contemplation, preparation, and we've got to be real about the fact that somebody who we stage, generally in maintenance, part of substance use and mental health and what's going on in our world right now is that somebody could go back to being earlier on in the stages of change and needing different interventions at any point in time. And so that's the thing about the stages of change. We've really got to adequately fund, sustain, invest in, hold with respect all these services that meet people where they're at across the stages of change. A couple ways that we do this here in the Harm Reduction Center at Evergreen Health. Walk-in, mobile, and peer-delivered syringe exchange, a lot of hepatitis C and HIV testing, low-threshold buprenorphine, supportive conversations about managed safer use, linkage to other services in our Drug User Health Coalition. Naomi, just to help bring us home, do you want to, you're particularly well-versed at talking about stigma. Would you like to chime in here before we end?
Sure, absolutely. Thanks, Emma. So a little bit about the stigma behind drug use. It's defined in the dictionary as being the experience of being deeply discredited, to be stigmatized, is to be held in contempt, shunned, or rendered socially invisible because of a socially disapproved status. This is such an important topic because it affects every aspect of people reaching out for support in the middle of the stages of change. It can cause major harm to people in their social lives. The chronic stress of discrimination may affect the mental and social health of individuals who use drugs. They can feel pushed to the outskirts of society and may lose touch with their community and family. Sifting through the participants list, I see that there are quite a few people here who work with people who use drugs. And I was wondering if perhaps you could put a little bit of a note in the chat about some stigma that they've noticed people have gone through. Just real quick as we're closing quickly on time. I'll read them off. They choose to be an addict. They aren't in recovery. They are weak. Medication-assisted treatment is not being clean. All people who use drugs are liars. Okay, thanks everybody. They are lazy. Okay. So how can we take the stigma that is perpetuated throughout people who use drugs in the communities? How can we start to change that as people that are helping other people? What would that look like? So a couple of things that I have come across as being super helpful to fight the stigma is to be aware of facial expressions, body language, or microaggressions. This is something that I'm not great at. If I have a thought come across my head, it usually plays out in my face. So it's something that I have to work at every day. Advocate for the rights of people who use drugs. Promote factual information. Sometimes it can be a little bit difficult to figure out what is fact and what is a myth. And shift the language. Some examples that I have about shifting the language is we can turn it, well, there's another slide on that too, but we can turn it from an aggressive sort of speaking to people into opening communication surrounding substance use, surrounding the person and not what they're specifically experiencing. If we meet people as humans and talk about the human things that they're going through, it can really open up the doors to say, you know what, maybe I can talk to you about some other things that are going on in my life that are really affecting me and causing me to use more drugs than I would have before. So no matter where people are in the stages of change, communication can really open up the door to trust and provide a better treatment plan or a better way of looking at the human as a whole instead of the human as a list of symptoms. So I could carry on about that, but this reference guide for person-centered language is fantastic. How can we turn what we talk about or how we approach people and the way that we word it into something different, into something that is human-centered, positive, negative, tox screen, instead of saying a dirty or clean urine. Use the term used or unused syringe instead of a dirty or a clean needle. Thank you so much, everyone, for your feedback on this. And if, of course, any more questions, we'll do that at the end.
Thanks, Naomi. Yeah, Naomi has a long professional history as a peer recovery advocate. So I, especially appreciate your comments about stigma. And I think the thing about language is, we really want to talk about language like in the job interview that early on with folks so that they know what the expectations are of being in a stigma-free workplace. And we try to use person-first language, the stuff on the left on this slide, whether or not patients or clients are around us. In other words, even when you're talking with your colleagues or your friends or your family, the expectation in when it comes to harm reduction is that you're using the language on the left. And that brings us to the end of our conversation about harm reduction today. And really, we could probably go on for another 7 or 8 hours with all of you. Our contact information is here on the last slide. We have gone to about 1 o'clock at this point, and so I don't know if anybody has a couple minutes to ask some burning question or share some burning comment that you really want to get out. But I just really want to express gratitude again to Kathleen and Amy for putting on a really rock star training series, actually. I can't wait to take the existential therapy talk in a couple months. So thank you for including us. We were really honored to be a part of it.
Great to have you with us. Thank you.
Thank you so much.
I don't see any questions that came in unless you caught anything, Amy.
Just, can you post the link to the evaluation so folks can get that?
I just did. I posted both. I posted the link to the evaluation, and I also posted the link to our May session. Again, thank you, Emma and Naomi. That was great. Thank you all for participating in our session today, and thank you, Amy, for monitoring the chat. Again, our May session will be on LGBTQ+ concerns for youth and families. So again, 4th Tuesday of the month from noon to 1. You can also visit our website if you want to look at any of the past presentations. If you're interested in being a presenter, please let us know. If you have ideas for topics you'd like to learn more about, we'd like to know that too. So you can write that in your evaluation or you can email Amy. Again, thank you, Emma and Naomi, for a wonderful presentation, and thank you all for being part of our collaborative.